Hello. Today we will be talking about product QC and product storage and expiration. Very briefly, going to go over the storage temperatures and expirations of different types of blood products. This is all from the AABB reference standards. So they have a very nice chart that lists the component, the storage. There's also different transport temperatures that are allowed, and then different expiration dates. This is the best thing to study if you have the up-to-date one. So the one pictured here is the 33rd edition. I only have the 32nd edition. Things are constantly being changed, so it's really important that you're looking at the most up-to-date edition. And there's also the circular information that has a lot of this information in it. That is, I believe we have it in PDF form, and it is really good information too. So just going over these briefly. There's whole blood, which whole blood went away for a while, and now it's coming back. It's mostly used for traumas, and sometimes even helicopters and ambulances will carry whole blood on their vehicles for traumas. So this should be stored between 1 to 6 degrees Celsius. It's also really important to discuss. You should always have a range for your storage temperature. Most of us have our fridges set at 4 degrees, but if someone says, what's the storage temperature? You can't say 4 degrees, because that would mean if it goes to 5 degrees when the door opens, it would be out of temp, and then that would be a deviation. So you always want to have a range, an acceptable range. Just like room temp, if you say we store platelets at room temp, you need to have a range for what is room temp, because room temp in Florida might be something completely different than room temp in Alaska. So it's really important we're all using the same terminology, because we do get blood from other blood centers, and we need to know that they're following the same guidelines that we are. So whole blood is normally drawn in either CPDA1 or CPD or CP2D. There's a separate lecture on additives and anticoagulants, and that'll go into specifics on that. But CPDA1 is 35 days expiration, and CPD and CP2D are 21 days expiration. Platelets should be stored at room temperature, and that's 20 to 24 degrees Celsius with agitation. They historically have a 5-day expiration date, but that all changed last year. And I have another slide to go over that because it's quite complicated. There's also now cold storage platelets. So those are becoming more popular. A lot of blood centers are validating those. And they have completely different criteria. For RBCs, they should be stored between 4 and 6 degrees Celsius. The expiration date depends on the additive, or if there is an additive present. So CPDA1 packed red cells are stored for 35 days. The AS1, AS3, AS5, and there's AS7 now that just got FDA approval, are 42-day expiration dates. If RBCs are frozen, they are good for 10 years. There's also cryoprecipitate, which is sometimes also called AHF, or antihemolytic factor. It is stored at less than negative 18 degrees Celsius, and it's good for 1 year. There's FFP, which is fresh frozen plasma. If stored at less than negative 18 degrees Celsius, the expiration date is 1 year. And if stored at less than negative 65 degrees Celsius, the expiration date is 7 years. Most people don't like storing it that cold because it makes the bag very brittle, so it's more likely to break whenever it is thawed. So most people will store it at less than negative 18 degrees Celsius. And then there's granulocytes, which is really just a lot of WBCs, they are stored at room temperature, 20 to 24 degrees Celsius, for 24 hours. And you want to transfuse those as soon as possible because they die pretty quickly. So this is kind of a breakdown of the new platelet strategy. And the expiration date is based on the bacterial monitoring strategy. So there's single-step strategies, and then there's two-step strategies. And this will actually be covered on one of the slides further down. But I do like this picture. I think it's really nice visual to help you understand the expiration dates. Okay, this is kind of a side note before we start discussing QC or quality control for the actual blood products. There are sterile docking procedures. So sterile docking can be used for lots of reasons. You can attach a sample pouch to take a QC sample. You can connect a bunch of platelets or a bunch of cryo together to pool them together to make one big product. You can prepare small aliquots for babies and infants. And you can connect a leukocyte removal filter so that you can try to get all the WBCs out of a product. This should be, like it implies, a sterile process. So you are connecting two tubes together sterilely so that there's no introduction of air or anything else to the actual blood product. So sterile docking is considered a closed system if the seal or weld is intact. So every time you sterile weld something to a unit, you have to check the seal to make sure that it does not appear broken or there's no leaking. If you break the seal and there's fluid coming out, that is now an open system. So why do we care if it's closed or open? Because it changes the expiration date of the product. So you can see in this chart, RBCs that have an open system are only good for 24 hours. Platelets or thawed cryo are only good for 4 hours. And the difference between these two are RBCs are stored at refrigerated temperatures, and platelets and thawed cryo are kept at room temperature. So the bacteria, if introduced, would be more likely to grow more rapidly at room temperature than in the fridge. So that's why there's such a short expiration date. So what is product QC? Product QC is a big thing for blood centers or any manufacturing facility. The purpose is to ensure the production of safe and effective blood and blood components. All manufacturing processes, procedures, and equipment are validated before implementation and are monitored on a regular basis. All employees, donor services, and component staff must be well trained and evaluated for their competency. And the final contents of transfusible blood components are evaluated regularly to ensure that they meet the minimum regulatory standards. So where do these standards come from? Quality control frequency and expectations are determined by the blood center, the FDA, and the AABB. The AABB writes their standards based on the FDA recommendations. And also certain manufacturers have recommendations for their instruments or component bags. The Code of Federal Regulation and FDA guidances have federal requirements listed. The AABB releases standards to help comply with these requirements. The blood center can always choose to have stricter standards if they like. So the AABB standards also have a very nice chapter on each product type and the frequency it needs to be tested and what the expectations of that testing are. So for platelets, the minimum number are 4 per month or 1% of number produced, whichever is greater. And this goes by collection site. We have a lot of different platelet types. Most platelets nowadays are apheresis platelets. Most platelets are not made from a whole blood donation. So for the apheresis platelets, the donor is collected on an instrument. The RBCs are returned to the donor, and only the platelets and plasma are collected. So at least 90% of components sampled must contain greater than 3 × 10 to the 11th platelet, and they must have a pH of 6.2 or greater at the end of allowable storage or time of issue. A lower pH might be indicative of bacterial contamination. If they are labeled as leukoreduced, the residual white blood cell count must be less than 5 million in at least 95% of components sampled. We also have another platelet that it is an apheresis platelet, but it's called a PAS, or platelet additive solution apheresis platelet. So in these, it's very similar to the normal apheresis platelet, but they draw it with a little bit less plasma, and they add the platelet additive solution for a storage solution. So it has very little platelet or plasma on the platelets. And they have the same criteria, QC criteria, as the apheresis platelets. So we also have the single or random donor platelets. These are platelets derived from whole blood collection. And these are usually not sent to the hospital. These would be made and then pooled to make a bigger product. At least 90% sampled have to have a pH greater than 6.2, and these actually only need greater than 5.5 × 10 to the 10th platelets per bag. That's if they're being issued to a hospital. We don't issue them personally. We pool them into an Acrodose product. So we will take 4 to 6 random donor platelets, pool them together. They have to have a platelet count between 2.2 and 5.8 × 10 to the 11th. And to be leukoreduced, the Acrodose has to be less than 5 million WBCs per unit. And same pH. All the platelet products have to have a pH greater than 6.2. There are also pathogen-reduced platelets. These are normal apheresis platelets. They go through some kind of pathogen-reduced or reducing process. Intercept is the only FDA-approved method at this time. There's another method that was being investigated in clinical trials called Mirasol, but it got paused during COVID, so I'm not sure what the process of that clinical trial is right now. So right now we have Intercept platelets. Same criteria for platelet count and WBC count. And we will talk about what happens during pathogen reduction in one of the slides later in this lecture. Okay, now we have cryo or AHF. Cryo is the cold, insoluble portion of plasma. Cryo will precipitate when FFP is thawed at 1 to 6 degrees Celsius. After cryo is separated from the plasma, it must be refrozen within 1 hour. Factor VIII breaks down very quickly. The volume is usually 10 to 20 mils, so they're often pooled together because of the small volume and dosage. The expiration date is 12 months after the original collection, and it's stored at less than -18 degrees Celsius. The AABB standards require that each unit have greater than 80 IU factor VIII activity, that's international units, and greater than or equal to 150 milligrams of fibrinogen. FDA requires testing of 4 units per month, and that is per manufacturing facility. So we have 6 component labs that make this, so all 6 labs have to send a minimum of 4 units per month. If pooled, we multiply the factor amount by the number pooled to get what the requirement is. So if 10 components were contained in the pool, the factor content would be 80 times 10, or 800 international units. And the fibrinogen would be 150 times 10, or 1,500 milligrams. Thawed cryo has an expiration date of 6 hours, and it is stored at room temperature. It should not be stored in the refrigerator. If for some reason it is pulled in an open system, it would be a 4-hour expiration date. So we do make pools here at the donor center, so hospitals can just order the pools, but some hospitals may prefer to do their own pooling, so they might just order 5 units and then pool them together themselves. At room temperature, the mean factor VIII level declines 10% in 1 hour, 20% in 2 hours, and 30% in 3 hours. So that is why it is such a short expiration date. So we also have a new product called pathogen-reduced cryoprecipitate fibrinogen complex. This was created because the short expiration of cryo is not ideal, because if a hospital thaws it, they have to transfuse within 6 hours, and if they don't, then they just have to throw it away. Factor VIII is what degrades so quickly, and usually if a patient needs factor VIII, they're going to get a factor VIII concentrate. They're not going to get cryo. So they developed this process for pathogen reducing cryo, and it is only good for fibrinogen. You don't issue it to a patient that needs factor VIII, only fibrinogen. So once it's thawed, it has a 5-day expiration date at room temperature. So it's much easier for the hospital to work at. Again, with these, you don't want to store in the refrigerator, and it has the same fibrinogen QC standard as normal cryo, which is greater than 150 milligrams per unit. Okay, now we have granulocytes. This is not a product we normally make. It would be specific for a patient that needs it because it's such a short expiration date. It's also used for research a lot. You can prepare these from whole blood. It's basically isolating the buffy coat, or they can be collected by cytopheresis or apheresis, and we would call those a leukopak. So that would be the large one over here, and then the small one would be the buffy coat. When you're collecting by apheresis, the donors may be given steroids to increase the WBC count. And these are used for adults that are in compromised patients that have like no neutrophils and they can't treat sepsis. Or they can be used for infants that have sepsis and have an extremely low WBC count. So it's basically just giving them an immune system for a very short period of time, hoping that they can recover and start making their own. These have to contain at least 1 × 10 to the 10th granulocytes. They're stored at room temperature. Because they are so bloody, they must be cross-matched, and you want to transfuse them as quickly as possible. Okay, there are lots of different types of red cell units. So you can have RBCs made and processed from whole blood, or you can have RBCs collected by apheresis. The QC requirements depend on if additives are present and if they are leukoreduced. Okay, for all units, regardless of where they came from, whole blood or apheresis, to be labeled leukoreduced, you always have to have a WBC less than 5 million. For CPDA1 units, they do not have additive. So there is a rule for all RBCs that do not have additive solutions must have a hematocrit less than 80%. And the RBC recovery must be 85% when you leukoreduce those products. And that's for either with or without additive. The AS1 and AS3, the absolute RBC volume must be greater than 128 mils. And then just a side note over here, CPDA1 units have historically been used for intrauterine and neonate transfusions due to the lack of mannitol. AS3 units are a viable option as they also do not contain mannitol. Moving on to apheresis RBCs. these are RBCs collected on an instrument. We use two different systems, TREMA or ALEX. So they can be collected as a 2 RBC, which are the end product would be 2 RBC units, a single unit recovery, which would be just 1 RBC, or they can be a concurrent RBC, which is when a donor will donate a platelet product and an RBC product. So on these, we test the hematocrit. Before filtration, at least 95% of the components sampled must have greater than 50 grams of hemoglobin or 150 mils of RBC volume per unit. After it's filtered and it's leukoreduced, 80 or 95% of the components sampled must have greater than 42.5 grams of hemoglobin or greater than 128 mils per unit. To be leukoreduced, it must have less than 5 million WBCs. And just a side note, some procedures filter during the collection process and others must be filtered after collection. So for example, the ALEX single unit recovery, it doesn't get filtered on the instrument, so they have to add a filtration system, sterile dock, to filter the unit. Okay, so now we'll start talking about the bacterial monitoring of platelets. To address bacterial contamination and transfusion-related sepsis and fatalities, FDA established new regulations for bacterial monitoring of platelets. This went into effect in October of 2021. There's several strategies to choose from. One is to pathogen reduce your platelets. If you do that, you do not have to collect any samples or test in any other way. The other steps require a culture. So there's the single step strategy and then a two-step strategy. If you do if you want a 5-day expiration, you can collect a large volume delayed sample at greater than 36 hours. And that's it. You just collect 2. Most people use BAC-T bottles. You do an anaerobic and an aerobic bottle, and then that platelet is good for 5 days. Or if you take your initial culture at greater than 24 hours, it expires at day 3, but you can take a second culture to extend it up to 5 days, or you can perform rapid testing to extend it to 5 days. We do the 7-day testing, so we wait until 48 hours to sample, and then you have a 7-day expiration date. You can also choose any of these other methods to get it to 7 days, but it's less work if you just wait to sample the BAC-T bottles, and then you have 7 days. So the BAC-T bottles that we use, these are the examples. So we use a BPA and BPN. The BPA is aerobic and the BPN is anaerobic. And you can see the picture on the top right is little fungal balls growing in one of our BAC-T bottles. So you can see the bottom of the bottles, they start out blue, and it uses CO2 concentration as a surrogate marker for bacterial growth. So after they're inoculated, if microorganisms are present, they will multiply and generate CO2. As the CO2 levels rise, the sensor in the bottle will turn yellow. And the BAC-T instrument monitors and detects the light reflected from the bottle. So as the sensor changes color, then it will flag that bottle as positive. So the rapid testing that was mentioned, the only approved rapid test is the Virax PGD Prime assay. This is a rapid qualitative immunoassay, very similar to like a pregnancy test. You add a bit of platelet, and if there is bacteria present, then you will get these lines down here. So the top instrument up here, your control line is positive, but there's no line, so this is a negative. And down here, your control line is present, but there are lots of lines, and GP and GN stand for gram positive and gram negative. So if there are any lines present, then that platelet is positive, and it would need to be discarded. A negative result will extend the platelet expiration by 24 hours. So if you do the early sampling and it expires on day 3, you can do a VRX test and it will push the expiration to day 4. Then you can do another one on day 5 and another one on day 6 up until day 7. Okay, so now pathogen reduction. So like I said, there's only one FDA-approved method, which is Intercept. The Intercept blood system is a product of Cerus Corporations. In the treatment, the platelet is mixed with a proprietary compound, which is, in this case, an amoxicillin, which is a psoralen, and it is exposed to UVA light. The UVA light activates the psoralen and allows it to bond with the nucleic acids present if there are pathogens present. So that amoxicillin will target the nucleic acids and intercalate or dock between the nucleic acid base pairs of DNA and RNA. The UVA illumination activates and it forms permanent cross-links between the DNA strands. That cross-linking prevents any further replication of the pathogen or leukocyte, and blocking transcription and translation renders it inactive. So now we're going to get into some examples of product QC. So we'll start with platelet products. We receive a pre-tube and a concentrate on all platelets that are drawn. The pre-tube is a whole blood sample from the donor. This should look like a normal CBC because it is a normal CBC. We do this testing because the platelet count is entered into our system, and that can be used the next time the platelet donates, or the next time the donor donates, so that we can use that platelet count to set the apheresis instrument to be more precise for that donor, because platelet counts do range from donor to donor. The concentrate sample is the sample from the actual platelet unit. This is used to determine the absolute platelet count, and this count determines if the product can be split into multiple units or needs to be labeled as a low count, which we'll go through some examples. For WBC testing, right now we use WBC by flow cytometry. This assay gives you the result in WBC per microliter by comparing the WBC events to bead events. So we use this tube you see in the center, and you see a little teeny bead at the bottom. That is actually lyophilized beads, and for each lot number, they give you the specific number of beads in that tube. So if you add your sample to that tube, then you know there's this many beads, and you can compare that. It's just a ratio between the two. So we have it set up so that it will gate on the bead population and on the WBC population. So it's just comparing the two. And to get the absolute WBC in the product, you just multiply the WBCs per microliter times 1,000 times the product volume in mil. So here's a platelet example. So to get the absolute platelet count, same thing as WBC, you multiply the volume times the concentrate count times 1,000 to convert the mil to microliter, or either way. In this example, we have a platelet count of 1,189. Notice the unit is 10 to the third per microliter. This platelet unit is 392 mils. So you multiply 1189 times 1000 times 392, and that gives you an absolute platelet count of 4.7 times 10 to the 11th. So does this meet the QC criteria of greater than 3 times 10 to the 11th? Yes, it does. So the same platelet needs WBC testing. So we get a result of 39.7 WBCs per microliter. Our product volume is still 392 mils, so we're going to multiply 39.7 times 1000 times 392, which comes out to 15.6 times 10 to the 6th. So is this product leukoreduced? No, it is not leukoreduced, because a apheresis platelet must have less than 5 million, 5 times 10 to the 6th. And this unit has 15.6 times 10 to the 6th. So when we test our RBC units on Sysmex, the result should look pretty similar to this. Those units should have a pretty low platelet count and a pretty low WBC count too, if it's leukoreduced. So we use the hematocrit from a packed RBC unit, and we need to determine the absolute RBC volume, which is the volume of that unit that are RBCs. So we will do that on the next slide. So here's an example of a double red unit. So we call double reds O1 and O2. The first one has a volume of 353. The second one has a volume of 355. So we ran our Sysmex and we ran flow on these. So the O1, to get the absolute RBC volume, you multiply the hematocrit by the RBC volume, and to get the WBC, same as in platelets, multiply the WBC per microliter times 1000 times the volume. So in unit 1, our hematocrit is 59.7. Multiply that by 353, which gives us 211 mils. And if you don't know what the hematocrit is telling you, the hematocrit is the percent of that product that is RBC. So when you spin the tube down, if your hematocrit is 50%, then the tube should look 50% RBCs, 50% plasma. So 211 is the unit O1's RBC volume. Then our WBC for unit 1 is 0.4 WBCs per microliter. So we multiply 0.4 times 1000 times 353, the unit volume, and we get 1.4 times 10 to the 5th. For unit 2, our volume is 355, our hematocrit is 60.2, so just multiply those two numbers and we get 214 mils. For WBC, we have 0.1 WBCs per microliter times 1000 times 355, so we get 3.6 times 10 to the 4th. So are both of these units acceptable? So our leukoreduced apheresis RBCs must have greater than 128 mils RBC volume. So unit 1 has 211, unit 2 has 214, so they are both acceptable. They must have less than 5 million WBCs, and they are both acceptable. Okay, now we'll do a cryo example. And just in case you thought you'd never use lab math or the metric system, we're going to use some of it here. So the first thing you need to do is measure the unit you're working with, and usually we'll measure volume in mils. So we need to convert that to deciliters because the instrument gives us the results per deciliter. So the instrument says factor 8%, and that equals international units per deciliter. So to get the final unit, factor 8, you would multiply the factor 8 from the instrument times the volume in deciliters. And for fibrinogen, it gives us the milligrams per deciliter. So we would multiply that by the volume in deciliters. So in our first example, we have a pool of 5. We measure the product, 169 mils, convert that to deciliter, which is 1.69. We multiply the number for factor 8 from the instrument, and that gives us 886 international units per unit. For fibrinogen, we get 2,203 milligrams per deciliter, multiply it by the volume, and we get 3,723 milligrams per unit. Our second example, we have a pool of 10, measure it, convert it to deciliters, and then multiply the values from the instrument to get your values per unit. So now we'll discuss if these are acceptable. So remember, if you have pooled cryo, you multiply the required factor amount by the number of units pooled. So for a pool of 5, you have 80 times 5, or 400 international units required. For fibrinogen, you have 150 times 5, or 750. So is our pool of 5 acceptable? We have 886, so that is greater than 400, so we're okay there. And then we have 3,723 fibrinogen. It is greater than 750, so we're okay there. For our pool of 10, we've multiplied 80 times 10, so it needs to be 800, and then 150 times 10 needs to be 1,500. So our factor 8, almost 2,000, so it's very acceptable for factor 8. And for fibrinogen, we have 8,000 milligrams per unit, so it is much higher than 1,500 milligrams as well. So both of these units are acceptable. And that is all I have for today. These are my cats helping me study. So I hope this lecture wasn't too overwhelming. It is a lot of math. You just have to remember the calculations, and a lot of them make sense. So I will put some homework together and post it, and then I would go through those questions. And then if you still have questions, then get back to me.